Hi everyone. My Neurorounds presentation is going to be on the clinical features of Raised ICP, and then briefly distinguish between an acute presentation versus a subacute or chronic presentation. In terms of our learning objectives, we're going to be discussing the concept of intracranial pressure and some of the things that determine it, and this is obviously a review for most of us. Then we'll discuss Raised ICP, how it increases the intracranial pressure and the different causes of it. And lastly, we'll focus on the actual presentation of Raised ICP, which is the main part of this presentation in terms of its signs, symptoms, and some of the investigations that we can do, and how this may differ when it's an acute increase in intracranial pressure versus the chronic changes that have time for compensation. So an average skull has a certain volume, and in an adult it's generally about 1,500 mils. The majority of that is brain tissue, and then we also have cerebrospinal fluid as well as blood, each about 100 cc, sometimes a little bit more, sometimes a little bit less. And it's an enclosed space, so all these components together create a certain pressure inside the skull, which is the intracranial pressure. In general, in an adult, it's less than 10 to 15 millimeters of mercury. And the way that you can measure the gold standard is to have an intraventricular catheter that can transduce your pressure. Generally, you can put it into the lateral ventricle or the subarachnoid or subdural. And it's an important thing to have when you need to monitor your ICP closely, especially with deterioration in your GCS or in people who you need to ensure adequate cerebral perfusion pressures. And so you can have that in and actually measure the ICP itself. The ICP values actually are different in children and neonates. So in children, about 3 to 7 millimeters of mercury, and in neonates, it's actually 1.5 to 6. But in this presentation, we're going to focus more on the adult neuroanesthesia and the adult ICP. And when we do have a transducer, when we look at the waveform, there's ways to analyze it. So as you can see in our middle image here, there's variation in the ICP in a normal healthy adult based on a respiratory variation. So depending on inspiration versus expiration, it can go up and down, and whether you're spontaneous versus being ventilated. And then you can also have variation with your heart rate and your pulse. And then within each of these pulse variations, you can actually further break it down, and this is where we can get the P1, P2, and P3 components. And the P1 is thought to be the actual arterial pulsation. The P2 is thought to be a representation of intracranial compliance. Generally, it's lower than P1, and then P3. I read different kind of representations, but it's thought to be venous pulsation or even the dicrotic notch. And we can actually, we'll come back to this later on, but the tracing can also start to suggest when there is raised ICP. So now I'm discussing the concept of raised ICP. As I just mentioned, the skull is an enclosed space that's non-compliant. And so the volume is fixed, and this leads to the Monroe-Kelly doctrine, which is that the volume of the skull is a representation of the three components that we already mentioned, and that an increase in one of the components has to be met by a decrease in another component, or you get an increase in your ICP or the pressure. And so when we look at the graph here, as your volume increases, there's limited amount of compensation until an increase in a component of an intracranial tissue, for instance, being a tumor, causes a rapid and exponential increase in your intracranial pressure. Now, raised ICP is generally defined as a pressure over 20 to 30 millimeters of mercury. but that doesn't mean that a pressure of 20 is not really significant or mild. And in fact, you can get herniation with as low as 20 when you have certain pathologies such as temporal mass. And generally it's thought that as ICP approaches about 40 millimeters of mercury, you need emergent treatment. And generally that's thought to be a surgical correction while you temporize with other measures. So there are many reasons why you can have a raised intracranial pressure. Generally, we focus on that first category shown in this table, which is things like hematomas, subdural or epidural, things like tumors, so whether they're primary like a glioma or metastasis, and then infections such as an abscess. Certainly can be also secondary to a traumatic brain injury. You can have obstruction of CSF drainage and hydrocephalus, and then other causes such as idiopathic intracranial hypertension or encephalitis, meningitis, other less common reasons for raised ICP. As you get this increase in the intracranial pressure, it can create pressure gradients within the brain. And so you can get pressure of the brain onto the skull, and this can cause ischemic changes, as well as pressure of the different brain components onto each other. And as the pressure actually starts to increase, it can start to affect cerebral perfusion, which, as we know, is your mean arterial pressure subtracted by your ICP. And so certainly if your MAP is constant as your ICP increases, your perfusion decreases. And so that can also lead to ischemic changes, which can cause edema, worsening of the ICP, and then subsequently a further decrease in your perfusion. And this can be a downward spiral as well. Now getting onto the main component of the presentation, which is how raised ICP actually presents. A lot of the things that we tend to think of as raised ICP is actually not the pressure in itself, but actually the shifts that you can get in your structures within your brain. And we'll also discuss that a lot of the times it's actually the pathology itself that can cause the symptoms, not the ICP. So that is a distinguishing factor. Generally, in terms of symptoms, patients can describe a headache. It's generally described as a throbbing headache, and it tends to be worse in the morning and actually wake people up from sleep, and that's generally a red flag for these headaches. And it's thought to be secondary to the increase in the PaCO2, which would increase your vasodilatation and your ICP. It's also thought to be worsened by coughing or sneezing or exertion, which also makes sense as it can increase your ICP. You can get change or loss in your vision. You can also get some vomiting, and generally it's thought to actually be a late feature. So by that point, you actually have significant disease burden. And even though you can get nausea sometimes, a red flag would actually be vomiting without nausea. And then as it progresses, you can get confusion and changes in your mentation, as well as seizures. Now, getting onto the types of things that we can look for on our physical examination when we suspect raised ICP. I think a lot of us also think of focal neurological deficits, because a lot of the times it does go hand in hand with the raised ICP, but generally, the raised ICP in itself doesn't cause focal neurological deficits unless it happens to compress onto that region from herniation or compression onto the skull. But the focal neurological deficits are usually from the pathology in itself. So if a tumor compresses on nearby structures that are responsible for motor function or sensory function. But the ICP itself, it can cause gaze paresis as you get compression of some of the cranial nerves as well as ptosis. Papilledema is actually something that most people think about when they think of raised ICP. And you can certainly have it, but it does take a few days to develop. So in an acute situation, not necessarily something that you'll see that often. you can get fundal hemorrhages in an acute setting, and generally that's thought to be secondary to an acute and more severe increase in your ICP. And actually, in some cases, you don't get papilledema in raised ICP, and it's also thought to not always be present in traumatic brain injury, even if you have a raised ICP. You can have pupillary changes. Again, this is getting more into the advanced raised ICP and herniation, GCS deterioration as you get caudal displacement of the diencephalon and midbrain. You can get posturing as things progress, and brain herniation starts to develop, whether it's transtentorial or tonsillar or subfalcine. And generally, that's when we're quite concerned. And then the other thing that a lot of people kind of think about is Cushing's reflex, which is a hypertension along with bradycardia, which is seen but is generally quite a late sign. So by the time you get changes in your blood pressure and your pulse and your respiratory pattern, it's usually quite late. And so at that point, it's usually you've gotten some ischemia and brain damage already. So getting to some of the investigations that can be done, one of the first things that's generally done is imaging, not necessarily for the raised ICP, but to look at what the pathology may be that are causing some of the symptoms you're concerned about. But with the ICP itself, some of the things that you can see on MRI or CT is effacement of the ventricle and basal cisterns. You can get loss of the differentiation between the gray and white matter, and then you can start to get some of the herniation that we discussed before, and potentially midline shift, but generally that's from the actual pathology itself. Midline shifts are not caused necessarily from the ICP. The other thing that can be done is looking at the ICP waveform. So certainly if it starts to increase, but also looking at its wave pattern. So talking about the P1, P2, P3 that we discussed in a previous slide. If you could look at the right bottom image here, you can see that in a normal brain, your P1 is greater than your P2. But as you start to lose your compliance and the ICP is starting to increase, your P2 actually increases and is higher than your P1. And as we mentioned before, your P2 is a reflection of your compliance. So as that increases and your P1 is actually smaller, that generally indicates that you're starting to lose your compliance. And as it actually increases further, these P1, P2, P3 patterns actually start to get blunted altogether. You can also get certain patterns. So the image on the bottom left are what are called plateau waves or A waves. And these are sudden increases in your ICP to values of about 50 millimeters of mercury or higher that are sustained for 5 to 20 minutes. And generally, they're kind of showing an increase in your ICP and a loss of your auto regulation. The middle there with the B are what are called B waves that are rhythmic oscillations of about 1 to 2 minutes. And they're kind of crescendo, decrescendo to levels of 20 to 30 millimeters of mercury. And these are, again, suggestive of raised ICP that's actually not able to compensate any further. So lastly, when we're talking about acute versus chronically raised ICP, when things occur more rapidly, as you can imagine, there's less time for compensation from this increase in ICP. And so you can get symptoms developing quite quickly. So sudden headache to loss of consciousness. And part of the thinking here is that the brain just does not have enough time to compensate. So let's say you have a sudden bleed. You don't really have compensation from your CSF or your tissue. And so the ICP increases rapidly and you can get herniation. As well as a midline shift. And so these are the cases where urgent imaging and management is quite important, where hyperventilation, protecting the airway and avoiding hypoxia and hypercarbia, promoting venous drainage with things like raising the head of the bed, giving osmotic agents and diuretics, and avoiding increase in airway pressure, so making sure that they're relaxed so that you don't get further increases in ICP. And the thought here is that you're trying to avoid further increase in the ICP and manage it as fast as possible, and usually in the form of surgical decompression. And in the meantime, you want to maintain your cerebral perfusion pressure. And part of the issue with an acute raise in your ICP, especially when it's from traumatic brain injury, is that you actually can lose your autoregulation. So generally we think of cerebral blood flow being autoregulated within a certain zone. But when you have disruption of that, any increases actually cause an increase in the flow and further worsening of the ICP. So it's quite important to maintain that perfusion, but also not increase your ICP before it can be surgically corrected. When we get to more of a chronically raised ICP, here the increase in the pressure has occurred over time. And so generally it's thought that there's better accommodation from the increased volume. So for instance, a tumor that develops slowly, there is still time for the tissues to adapt to this. It still follows the Monroe-Kelly doctrine. So at some point, you will start to get the increases in the ICP, and at that point, it will continue to increase. But the idea here is that the symptoms and things like herniation take time to develop, and you will get symptoms and signs well before you get the herniation. It can still certainly happen with some of these pathologies, but for instance, with something like idiopathic intracranial hypertension, you can get actually quite high ICP before you really get all the symptoms and deterioration of your status. And in fact, a lot of the times, the symptoms that are identified is actually not from the ICP itself, but actually from the pathology. And what I mean by that is a lot of the times when patients present, it's actually, for instance, a tumor compressing on nearby structures that cause symptoms that the patient first identifies rather than the ICP, which makes sense. And certainly based on the pathologies that you can have with this chronic increase in ICP, the treatment tends to differ as well, right? With a bleed, it's a sudden increase in the pressure, whereas, for instance, a tumor can cause a lot of edema in addition to its own structure. And so with that edema, things like steroids can be beneficial, whereas for traumatic brain injury, steroids are generally not thought to be effective. And so that's one of the main differences between acute versus chronically raised ICP. So that concludes my presentation on the clinical features of raised ICP. Certainly, I can answer any questions that are posted within a day or two. And my references are listed on the next slide. Thank you very much.